Hi, I'm Dr. Heyland, the creator of Planwell Guide. I want to share with you a story that was impactful for me and was part of the reason I developed Planwell Guide. One day when I was on call in the intensive care unit, I was paged urgently to the emergency room. An older patient had come to the ER gravely ill, and the ER doctor barely had time to put him on life supports and stabilize him. Only after the patient was stable, he went and talked to the family, and they were irate. They produced a living will that said if their dad were dying, that he didn't want heroics. And in their estimation, their dad's wishes were violated. They were upset, and I was called to deal with them and the subsequent care of the patient. After reviewing the patient and assessing his condition, I met with the family, heard their concerns, and asked, "Do you think your dad understood that when he said he didn't want heroics, that with 24, 48 hours of a breathing machine, I could probably get him off machines and back out the door like he was before he came in?" "Oh no," they said, "if there's a chance he could survive, sure, he would have wanted the machines." I explained that there was a probability that he could die if we didn't intervene with our machines, but there was a high probability that he could survive in good shape with our heroic measures that we use in the intensive care unit. This case illustrates how the traditional planning focused on end-of-life wishes, such as that done traditionally with a lawyer or in the context of traditional advanced care planning, is not useful and in fact may be harmful when people are seriously ill. Harmful in the sense that people come to hospital with a certain expectation of the care they might receive, and myself and other critical care doctors like me have to explain to them the difference between serious illness and end-of-life care. Some people find these time-sensitive life and death conversations very stressful. In the case I mentioned, the patient actually went on to do well and was discharged home the next week. But what if he would have actually worsened and after 7 or 10 days stay in the ICU, he died? How would the family have felt about his care then? Many feel regret and sorrow that they didn't honor their loved one's final wishes in that kind of scenario. Can you see how the planning paradigm focused on end-of-life wishes under conditions of certainty don't map out onto how we make clinical decisions when treating patients with serious illness? Another common scenario that occurs in this context is that the patient survives their serious illness, but is left incapacitated, unable to look after themselves or their finances. Families experience considerable stress in trying to meet the needs of that vulnerable patient, and many times conflict erupts within the family as people have different ideas about what their loved one would have wanted or how best to use their resources. Frequently, relationships are damaged and legal services are required to resolve these matters. All of this could have been prevented with better planning. We need to change the way we prepare people and their families for serious illness. I call that Advanced Serious Illness Planning, or ASIP for short. It has medical, legal, and a financial dimension. It's kind of like a three-legged stool, and if one of the legs doesn't work right, well, then the stool doesn't work. At Planwell Guide, we've partnered with lawyers and financial planners to optimally prepare you and your family for possible future serious illness, so you can rest assured that you will get the care that is right for you with the least stress or burden on your family. Visit Planwell Guide today to get started on your plan.